So, thank you very much for the opportunity to talk to you about my research. It's a great day that you have put together. The research I'm going to talk about is a little more advanced than the two projects that you've heard about. Maybe some data that we've generated and seek advice about how we use the data going forward. I work at the University of Liverpool, and the work has been funded over the years by Crohn's and Colitis UK and Guts UK, and more recently also by a grant from the government, NIHR. Thank you. So you will all know that diagnosing inflammatory bowel disease requires invasive tests. Typically, we're looking at colonoscopy, maybe some endoscopies, particularly in children, poking and prodding, x-rays of some sorts and scans. And it's quite invasive, quite inconvenient, embarrassing, potentially uncomfortable. And that's a challenge for us. You'll know that Calprotectin has been used to help select patients for investigations to try and diagnose inflammatory bowel disease. And in monitoring IBD, it's been really very useful indeed, but it still has issues when making a diagnosis, particularly in children. And when we look at children, we find that about 40% of the results are incorrect. Now, calprotectin is a protein that's in white cells, and white cells go into the gut when the gut's inflamed. And we recognize that it tells us about inflammation. But if somebody's bleeding, maybe taking a painkiller, maybe there's a small polyp, even perhaps if you brushed your teeth too hard, there could be trace of blood in the stool, and these results can be misleading. So we're quite anxious, particularly in children, about relying upon calprotectin. So we've known for about 30 years that dogs can be used to support the diagnosis of cancer. And this began when there was a report in the BMJ of a dog that was very bothered by a mole on a patient's leg. Kept fussing over the mole. Eventually the patient went to the GP, and the GP did some investigations, and that one particular mole turned out to be a melanoma. And that led to a lot of interest in the potential for dogs to diagnose cancer from smell. And that's been extended into the medical detection dogs, which you may have heard about in the setting of COVID. And they've been trained to try to recognize the smell of COVID. So we've taken the same concept of sniffing into the laboratory. Now, as a clinician, I know that many patients are embarrassed by the bathroom smell when they have a flare of inflammatory bowel disease. And we thought we could use that information from the odor to help us to characterize what's going on in the intestine. Does a person have inflammatory bowel disease? Is that disease flaring? And also to drill down onto the chemicals involved in that smell to try and understand more about what's going on in order to turn disease off. So we've looked at fecal gases, mainly in adults, and we've published some data on this. And we've been able to show that there's a difference in the pattern of molecules in the gases in adults when they have inflammatory bowel disease. And we were very excited by this. The difficulty was that pretty much all of them had a diagnosis of IBD and were taking therapy. And so we're very keen to get patients earlier in their disease course. And so we went to children with our colleagues at Alder Hey. So we've been looking at newly presenting children who might later have been diagnosed with IBD and people who weren't, another control group. And also we looked at those same children before they started therapy and a few months later, hopefully having responded to therapy. To do the study, we asked over 200 patients to take part, 332 who were later found to have IBD, so we got them before the diagnosis was confirmed, before therapy was started, and matched controls, same age, same sex, same hospital. And we got stool samples from these children collected at home, sent to the hospital, and then to our lab using a cold chain so everything was frozen all the time. And then we looked at the gases coming off the stool using two different techniques, a fairly standard hospital technique causing mass spectroscopy, which is available in most NHS hospitals, and a newer technique where we have a sensor that looks at the gases coming off the stool sample. Now, I don't like the smell of feces any more than you do. All this is done in very tightly contained containers. Otherwise, one sample would leak into the next and spoil the smells that we're looking at. So it's all very fresh. My lab does not smell of feces all the time. By looking at the compounds, what did we find? Well, we're very excited to say that in children in particular, there were several gases that were more abundant in the children with inflammatory bowel disease than those who didn't have inflammatory bowel disease. And there's another group of compounds common in the control group that kind of disappeared in the patients with inflammatory bowel disease. I always like it when the compounds go in different directions, because if everything's reduced, you think there might be a problem with the sample or machinery in a day. But if they go in a different direction within a set of data that you're looking at, that tends to give us encouragement that the results are real. So we found two very specific gases which were raised in the children with inflammatory bowel disease, in Crohn's and ulcerative colitis, but we were later able to separate out Crohn's and UC somewhat. And we found that when they went into remission, those two gases which had been raised came down towards a more normal level when the disease went into remission. There were some fatty acids that were reduced when they were active, and again, when they were treated, these fatty acids came up. Now, fatty acids, the most common one that you're familiar with perhaps is the smell of vinegar. It's not unusual for patients to say their stool smells of acid. I'm not quite sure what they're thinking of, but they're probably thinking of the smell of acetic acid. So acetic acid and a few other of these compounds change. So we've found that data using the complicated GC machine, but the sensor machine does the same job, and it's very easy to use. A sample goes in, we press a button, and there's a readout on a screen. And we've trained circuitry to interpret the patterns, and it's very, very sensitive and is able to diagnose Crohn's disease and ulcerative colitis from the controls with great accuracy. And we're doing complicated stats now to show this data is reproducible. Some of the samples were kept back and they're going to be analysed separately to see if the patterns we found in the first set are also found in the second set. And that will mean that the data is reproducible and gives more confidence in what we have been finding. So a natural question is, where do the gases come from? Now, we're all aware that our own bathroom smell is quite unique to us, but it's not as unique as you think. Behind the special odours that we think are our own, there's a complex range of molecules which we all make all the time, and they change subtly in the presence of disease. The gases may come from food, and they can directly come through from the flavourings in food. But many of the compounds don't come as the flavourings of food, they come from metabolism of the food, the basic building blocks of food. The fats, the carbohydrates, the proteins are broken down. And they're broken down by the biome, as Chris has talked about earlier, the bugs living in the gut. So depending on that blend of bugs in your gut, you will ferment and digest things slightly differently. And that's what's going on, we believe, in patients with inflammatory bowel disease. The bacteria differ, and we've now able to say that the fungi differ too. This is work we've only just completed in the last few days. And we can show that the metabolic pathways associated with fungi and bacteria are definitely different in the patients with inflammatory bowel disease. And this is enabling us to understand how those bugs contribute to what's going on. So we've completed that first work. We're drilling down now more onto the interaction between food and bugs and the compounds that we generate. And we think that from this data, we can say in future that a test based upon fecal gas analysis could be used to select children to go forward for more invasive testing. I think ultimately we'll want to have a look at the bowel, take a biopsy of the bowel to be really sure that what we have is inflammatory bowel disease. But instead of getting 40% of children wrong, over-diagnosing them, over-investigating them, we can do better than that by using these new tools. And it gives us another way of monitoring therapy. So we think there's a role for gas analysis, and we need to do more work in the future to compare the relative roles of gas analysis versus the Calprotectin. And we're doing that as we speak with these new devices which are being generated and could be rolled out in the future to a hospital near you. Now, none of these works are done in isolation. The clinical study funded by RFPB was led by Professor Stephen Allen, working at Alder Hey with his fellow, Dr. Balfour, but in collaboration with Bristol and in Birmingham. The clever stuff in the lab is done by my postdoc, Rachel Slater, and the fungal studies have been supported by Guts UK, and Dr. Frau's been doing those. And with Crohn's and Colitis UK, we're now doing the next piece of work to take these things forward. So I'm very grateful to share the data with you, and I'd like to ask a few questions in the next few slides about what we do next. So hopefully we can now move on to the paneling part. Thank you very much. So I'm rather hoping that you can now see some questions. Can somebody tell me if that's the case, please?
Would you like to launch the patients one or the parents one first, Chris?
If you could, that'd be great.
Yep, not a problem.
I don't know how to do that. I think that comes from you. Yes, please.
Yeah.
So we are very keen to, thank you very much, very keen to know how we're going to roll this out in the future. Thinking about yourselves or perhaps by your children, would you be prepared to give a stool sample to help make the diagnosis? Now, those of you familiar with calprotectins hopefully are familiar with the concept of what that needs. If the sample had to be kept frozen in your freezer overnight and we gave you suitable packaging, would you be prepared to collect it at home and then freeze it? Would you then be prepared to keep it alternatively in a picnic hamper with styrofoam, polystyrene, and a freezer pack as an alternative to your freezer? So in some studies, in some countries, it's very customary to send out these freezer packs, and we're doing it at the moment for bowel cancer. In one country, they actually posted out little mini freezers for small studies, but we can't do that large scale. So we'd use a freezer, we'd use a freezer pack. To collect the stool sample to help monitor the IBD rather than just to help make a diagnosis. We think there's, as I said already, benefits to it versus calprotectin, but it's not everyone's cup of tea. And here comes the crunch question. Would you rather have a colonoscopy or provide a stool sample to help monitor your inflammatory bowel disease? And so you could say here whether you want to have a colonoscopy future or stool sample or neither. Thank you very much. Please send us your answers. And I hope in the next few minutes we'll start to see the data coming in. And in the meantime, if you'd like to post some questions using the Q&A function, I'll do my best to try and answer anything that's arisen there. Thank you very much indeed. Now, I think I need to stop sharing now. I'm going to stop sharing and hope for the best. Here we go.
Okay, we'll give it a couple more seconds, another 30 seconds for the poll. We've got 80 people out of 120 have voted. So get your answers in.
I'm not sure if somebody's talking to me at the moment.
That was me, Jane.
Right, okay.
Okay.
Are there answers coming in? I don't know if I need to do something to help do that.
Yeah, I'm just going to close the polling now.
I can't see quite what's going on there. In the meantime, there are a couple of questions coming in, which is fabulous. Right. These are the final answers, are they?
Yeah.
Thank you very much. So I'm delighted that you would be prepared to collect the stool sample to help make a diagnosis. A couple of people aren't quite so convinced, but I'm glad 98% of people are. I'm reassured and intrigued that the majority of people would be prepared to put in a freezer at home. Interestingly, ethics committees have got a big issue with this. And when we were doing a student study, you won't believe the conversations that we had about what they thought students did with their fridges and their lack of domestic hygiene. I get that many people might prefer a freezer pack. I probably should have said which you prefer, but the data is very helpful. Thank you. Collect the sample at home monitoring. Brilliant. and providing a stool sample instead of a scope. That's just great. Thank you very much indeed. I rather hope we can keep a snapshot of this for me to return to later. So that's grand. Thank you very much for your feedback. I'm now going to look at the Q&A to see if questions for me have come in. Scrolling down, there's lots and lots of questions about fatigue from the previous speaker. So, what percentage of false positive, false negatives with Calpro in adults? Asks Sarah. So thank you, Sarah. She's concerned about routine testing. Yeah, okay. So we're aware that no test is perfect, and you're going to hear more about that for COVID, of course. In the setting of active inflammatory bowel disease and monitoring, we tend to look at the change in the level that you've got. So if we know that when you as an individual are unwell, it was, for example, 600, and it comes down 300, 200, we know we're going in the right direction. Obviously, the converse is also true. False positive, false negatives across the whole piece to making a diagnosis. We're probably better in adults and children. It's not quite clear why, but certainly in very young children, there are false positives without any known gut pathology, and no one understands that, but it's been looked at in the first few years of life extensively, and it is a problem there. So what we're struggling with now, Sarah, is to get the right cut point. And in different parts of the country, the level which we think is normal or abnormal varies. In Liverpool, it used to be 50. In Newcastle, it was 200. And in Glasgow, it was 250. So we don't know quite what works, but we realise that 50 is too low for Liverpool. And we're putting the level up in negotiation with GPs. Because if you start investigating everyone with a Calprotectin of 52, you get very few patients with inflammatory bowel disease. So that looks like a false positive. So if you move your level up to 200, then you get fewer of those. So it's all about the cut point in your population. I would argue that if the level's 200, there's something contributing. And so that would be important to deal with. Right, questions coming in. I think the next one for me is, at what stage of diagnosis would this technique be used? From Ricky, thank you. So I think it's got the best role at the moment in making a diagnosis, because that might offset a lot of investigations and prevent people having unnecessary scopes. Downstream, will it be used for monitoring? I think in some places it might be used for monitoring, but I think the main role is going to be in helping with the diagnosis at the beginning. Not because I don't think it has a role in monitoring, but we have other techniques which are already rolled out, and we're going to be competing with them. But early diagnosis for sure. Lovely question about diet. Is there a right or wrong on what you get to eat and drink? Is there a right or wrong? Jamie, I think if you're asking in the setting of the IBD, that's a different question. If it's about the diet in the setting of the testing, we're doing a lot to try and understand the contribution of diet to the data that we look at. And if we go past the flavorings and focus on the core compounds generated by metabolism, your diet doesn't change that as much as you might imagine. We're deeply involved in those studies at the moment. What's fascinating, though, is if you look at the effect of modulin, which is particularly used in children, we can see a huge change in the response, as you might imagine, when they're on modulin diet. But if across normal adults who are eating the range of foods that we associate with being a grown-up, there isn't as much variation as you might imagine, and we can still pick out those with inflammatory bowel disease separate from others. So we're about to do a comparison with UK data with Australian data. The samples are literally in the freezer, and in the next few months we're going to be looking at samples from India. Now, as you imagine, with an Indian diet, there's lots of herbs and spices that will make things quite complex, but the background of carbohydrate, protein, and whatever I've dismissed out, fats, is going to be there all the time, and the microbiome is going to interact with those. So we can ignore the flavorings from the coriander and focus on the metabolites. Will this test be used for adults? Definitely, Lucy. We have published some data on this in adults, and we think the data is really good. We're the order of 95% accurate in defining adults with inflammatory bowel disease, which is a long way better than Calpro. So we're excited to roll that out, and I am eager to set up more studies in that area going forward. What we're quite interested in too is other conditions where the microbiome is abnormal, such as irritable bowel syndrome. Now, a big problem with people with inflammatory bowel disease is they may have been told they've got IBS, and that's an issue that we have to tackle all the time. But 10% of the population have got irritable bowel syndrome, and fewer have got IBD. So that's the first challenge, and we're able to separate IBS from IBD in the majority of our patients, but not in some. And we're doing interesting work with Alex Ford at the moment from Leeds to look at IBS in patients with IBD. And that's going to be quite an interesting challenge for us to look at. So we can look at adults, we're keen to look at adults, and that'll be going forward. I'll be prepared to have a colonoscopy if it were more useful within the study, but about a total colectomy. Thank you, Polly. We have yet to do work on the stoma outputs and the effect of colectomy, but we have looked at the effect of a resection on our studies, so I think we can deal with that. There's a person saying my daughter's calprotectin levels are always normal even in the flare-up. Is that usual? That is a big problem. 79514. No name there, thank you. In some patients it's quite hard to explain what's going on, but we've known in the past that CRP doesn't always go up in patients in whom we can demonstrate disease when we scope them. We tend to get normal levels in some patients who've got isolated ileal Crohn's disease. Obviously, we don't know whether your daughter's disease is Crohn's disease or colonic. Colonic disease tends to be better represented with a calprotectin than isolated small bowel disease. And that might be the amount of calprotectin goes up, or the way in which it's diluted between the ileum and being passed to stool. But it is a challenge, and that to us means we just need to be holistic and listen to symptoms and find a nice alternative non-invasive test such as a stool sample. Sarah says, do you plan a similar study in adults? Yes, we're going to be doing more in adults, Sarah, definitely. It all comes down to time and funding, and we are literally poised to start our forthcoming study in collaboration with the Indian group in the next couple of months. The Australian study is an adult study, and we're fascinated to do more work in adults. Claire asks, really interesting, thank you. Have you found specific microbes and bacteria? Thank you, what a wonderful question. So our instinct is that in patients who've got inflammatory bowel disease, the bugs, as Chris was saying earlier, are different. And if we can manipulate those, that might be beneficial to patients. And that's something that's fascinated me for a very long time, is the change in IBD because of the inflammation? Does the inflammation drive the change in the bugs, or is there a primary change in the microbiome that leads to the disease? And there's some new work out of Glasgow that says if you've got a control group and a patient with active inflammatory bowel disease, they're separate. But when you treat the inflammatory bowel disease, they move into a third space. They don't go back to normal. They go to another zone again on the graphic. So it's fascinating to see these microbes are different. I think what we get from the compounds we look at is what the function of these bugs is. And it's probably more important to understand what the bugs are doing, the names of the bugs doing it. And so we're trying to connect these dots. And literally yesterday, I had a wonderful image sent to me. I would like to have shared it with you, but it's a bit like a wiring diagram, looking at the interaction between bugs that are bacteria and fungi and the metabolites and disease activity. So hot off the press, watch this space. Lactose intolerance, small bowel overgrowth impact these results. Thank you for that question, Elwyn. We need to understand more lactose intolerance. It's really quite common in patients with small bowel disease, and that's an area we've yet to dig into. I suspect the answer is that the small bowel overgrowth won't make such a big difference, but I think that the lactose intolerance will, but we need to do more work in looking into that. Lucy says definite merit.
We'll make this one the last one, Chris, if that's all right. Sorry to interrupt you.
That's okay. It was used from your child, diagnosed earlier. Yeah, so very sorry, Lisa. Just thank you for your supportive comments. Hopefully we'll prevent more people getting into your comment. Can I just answer Dawn's quick question? Alternative to the freezer? And the answer is basically your kind of picnic box in which you keep your drinks and your snacks cold with ice packs within it is the alternative to the freezer at home. We've done some work on that and we think it is viable and the results are stable. So thank you for those points. Lucy, thanks again. Grand.
Thank you very much.
Probably my time up, but thank you very much.